Hi, my name's Melissa McCool, and I'm the founder of Symptom Targeted Intervention, or STI. I created STI to help medical patients who are depressed but who are unwilling or unable to seek outpatient psychiatric care for their symptoms. As medical professionals, it's really frustrating when you have a depressed patient and you feel like you don't have the time or the skills or the resources to help your patient. After this training and after you learn STI, you are going to immediately be able to use these tools to help your patients. These interventions are quick and they're efficient and they're easy to understand and easy to use. So this training is comprised of 5 sections, and I'd like to talk about what we're going to be discussing in section 1. In section 1, we're going to discuss what is STI. We're going to discuss the story of STI, how it was created and how it's evolved, as well as the theoretical framework. Then we're going to talk about some of the research that's been done on STI, and switch gears by talking about the problem of depression and some of the current treatment options that are available. Then we'll talk about how STI is different from these other options. And finally, I'm going to help you learn how to identify depression in the medical setting. So what is STI? STI is a focused and active approach that helps clinicians manage depression in their medical patients. Using STI, the clinician and the patients identify the most problematic symptom of the depression, and then using cognitive, behavioral, and mindfulness interventions, they target that symptom. These cognitive, behavioral, and mindfulness interventions have been modified for use in the medical setting. So now that you all have a basic understanding of what STI is, I'd like to tell you about how STI was created and how it evolved. I'm a licensed clinical social worker based in Southern California, but the early part of my career was spent in New York City. After graduating from Columbia University with my master's in social work, I stayed in New York, and I worked in a hospital doing medical social work in the emergency room and on the floors, and I also worked in home care. I later started working in outpatient psychiatry in the psychiatric department. After taking some time to raise my family and moving to California, I got back into the working world and ended up in nephrology social work. So I worked at a dialysis clinic with dialysis patients. And I found myself really loving that job because when you work in a dialysis clinic, the patients come in 3 times a week for their life-saving treatments. So as a social worker, you really get to know your patients and you really get to know their families. So I started really caring about my patients, and what I found is that a lot of them were depressed. So at that time, the standard of care for depressed patients in the dialysis unit was to refer them to outpatient psychiatry. So I'd refer them to outpatient psychiatry, and lo and behold, they wouldn't go. And they wouldn't go for various reasons: transportation, cost, appointment burden. They didn't want the stigma of having to go to outpatient psychiatry, so they just wouldn't go, and they'd continue to be depressed, and their clinical outcomes were affected. So I became frustrated, and I thought, you know what, I have clinical training. I should be able to help these patients. So I did some research, and I discovered that the most evidence-based approach to treating depression is cognitive behavioral therapy. So I took a course on cognitive behavioral therapy, I read some books on it, and I decided I'm just going to help my patients on my own. I'm just going to figure this out. So when I started going out to the floor to use cognitive behavioral therapy and to start doing cognitive behavioral therapy, what I found is that it really didn't work. It really wasn't feasible because of the medical setting. It's so, as you guys know, working in the medical setting, it's fast-paced, it's busy, there are people coming and going, and so it's really difficult to have long stretches of time to sort of do clinical work for patients. I would find that I'd have 15, 20 minutes, stretches like that, where I could actually work with the patients. So what I found myself doing is basically saying to the patient, look, you know what, just tell me what's bothering you the most right now. What is really upsetting you? And what we would do is we would kind of come up with the one symptom that was bothering them, and I would use some of these interventions, these cognitive and behavioral interventions, and also some mindfulness interventions to kind of resolve this one particular symptom. And at the time I thought, you know what, at least I'm doing something. something's better than nothing. And that has sort of been my motto to some extent. Something's better than nothing, because at that time the patients weren't getting anything. So what I thought I would do is treat it one symptom at a time, just sort of chip away at the problem. But what happened, interestingly, is that after we addressed the one symptom and the symptom resolved using these, cognitive behavioral and mindfulness interventions, the whole thing changed. These patients just started getting better. The whole trajectory changed. And I found that really fascinating, that by basically focusing on one little element of the problem, that the problem itself changed and would resolve. And after thinking about it, I realized it's probably based on systems theory, which systems theory and Bowenian family therapy, which is kind of based on system theory, posits that if you take one element of a problem and you change that, or you take one element of a system and change it, that the whole system changes. So in Bowenian family therapy, if one member of the family changes, all the other family members have to change as a result as well. And so I think that's why symptom-targeted intervention started working, is because the symptom is a cluster, and if one symptom changes, the others change as well. So I found that really interesting. After I told one of my colleagues about what I was doing with my patients, she really encouraged me to sort of write up what I was doing. So I wrote a training manual for symptom-targeted intervention. We subsequently filmed a training video, and she had an idea let's do a pilot and train other social workers and see if their results are the same. And that led to the STI working group. We created a pilot. And what we did is we took 47 social workers in 17 different states and had them do STI. And these are the results of the research. What we found in this practice evaluation outcome with these 46 different social workers is that on average they spent an hour and a half over a 6-week period of time with their patients using STI. Their physical composite scores, which is a quality of life index, improved by 51%. Their MCS score, which is a mental health quality of life indicator, improved in 64% of the patients. And the CESD, which is a way to measure depression, their scores improved in 72.1% of the patients. Another interesting outcome was that the social workers themselves felt more confident measuring their outcomes as a result of doing STI. Some other recent research that is unpublished as of late but has come out is there is a large dialysis company that is using STI to help patients who have problems with adherence. And what they did is they used 732 patients in 400 of their clinics, and they found that there was improved compliance with medical treatments within 6 months for 76% of their patients. So basically 76% of their patients became more adherent using STI and some other clinical interventions. And as a result, because these results were so amazing, they started removing clerical tasks from 1,800 social workers around the country. So these social workers are doing more of these clinical interventions to help their patients. So let's talk about the problem of depression now. Depression is a public health epidemic, and in fact, by 2020, the World Health Organization predicts that depression will impose the second largest burden of health worldwide, right behind diabetes. Depression is a big problem in the medical setting. There are estimates between anywhere from 10 to 30% of medical patients are depressed. And as you guys may or may not know, depression has a very negative effect on these patients. There is an increase of morbidity and mortality with depressed patients. They're more likely to end up in the hospital, and they're more likely to die if they're depressed. And that's across all disease states. There's also a financial burden. $83 billion a year is spent on patients with depression in either medical expenses or lost productivity. And actually, in the work world, it's called presenteeism, which means a worker shows up who's depressed, and they're there physically, but mentally they're not there. So they're not really available. And also emotionally, when someone's depressed, they're not emotionally available to the people around them. So I recently read a statistic that each depressed person negatively affects 9 other people in their lives. So if you think about it, depression really has like a ripple effect. It's not just the patient, it's 9 other people that this person has contact with that are really negatively affected. And for me, this hit home when one of my patients' wives called me. This sort of middle-aged man had been quite depressed and quite irritable, and we had done STI and he'd gotten a lot better. And his wife called me a couple months later and basically said, "Thank you so much for helping my husband," because he, prior to sort of getting help, he had been having like up to 7, 8 rages a day. And after his depression sort of resolved, with the help of STI, he was only having like 1 rage every week or so, his wife said. And this man had a 4-year-old daughter. So for me, that was really powerful, that by helping this man, I helped his wife and I helped his daughter. So you have to think about that. When every person you help, there's a ripple effect, because it also helps the people all around them. So I want you to consider that. So depression really has very negative consequences and, adversely affects clinical outcomes for all these patients. Some of the treatment options, obviously, if a patient is willing and able to go for outpatient psychiatric help, that is the way to go. Meaning they see a therapist, they get medications if that's indicated. That is the best way for the patients to get better. However, only 12% of people who are depressed ever get any sort of mental health treatment. And that's just not medical patients. That's the general population. So if you think about it, 88% of the patients or people who are depressed get no treatment whatsoever. And for me, it's very upsetting that there has to be a better way to help these patients and these people. So I think there's a growing consensus and there's a growing recognition that we need to find a way, especially to help medical patients, because they're more likely to die, they're more likely to end up in the hospital. All their clinical outcomes are negatively affected by depression. There is definitely a growing consensus that we have to figure out a way to bring some of the mental health treatment into the medical setting. And there's a movement called collaborative care, which is essentially a psychiatrist and usually a clinic care manager sort of trying to help these patients, usually with medications and some very brief problem solving. But that's about it. And for that way, I'd like to discuss how STI is a little bit different. STI is different because unlike some of the other models that are being used in the medical setting, it utilizes a lot of evidence-based interventions. It's also been designed specifically for use in the medical setting. And STI is patient-driven. It's collaborative, meaning the patient and the clinician together are deciding what symptom to work on. But it's really patient-driven. It's not what the sort of social worker or the clinician wants the patient to work on. It's what the patient themselves wants to work on. It's also very brief. The average STI session is usually between 20 and 30 minutes for the first sort of session, and subsequent sessions are 10 to 15 minutes. And it's only focused on one problem. And this can seem like something that's not a positive, but actually in some ways it's very helpful, because a lot of patients have many, many psychosocial problems, as you all know. And it's very easy for patients to feel overwhelmed by their numerous problems, and it's also easy for the clinician or the social worker to feel overwhelmed by all of these problems. So by focusing on one element of the problem, people feel more empowered and more helpful. STI takes a public health approach, meaning the approach is to help as many people as possible. That it's not going to be perfect, but the perfect solution, which is outpatient psychiatry, doesn't work, and most people don't do it. So we need to think outside the box and really help as many people as possible. And to do STI, there's really no diagnosis that is needed, because you're treating what you see. Meaning you don't have to spend a lot of time trying to figure out, is this dysthymia? Is this an adjustment disorder? Is this a major depressive episode? It doesn't really matter what it is, because what you're doing is you're treating what you see and what the patient wants to work on. And the approach is experimental, meaning with some patients, you might try multiple interventions, and you sort of experiment with the patient to figure out what helps them and what works best. So now that we've talked about what a big problem depression is, I'd like to help you learn how to identify what patients you might like to try using STI with. And so I'd like to discuss depression as a broader topic so that you can kind of learn how to identify depression in your patients. So here's a couple ways that you might start identifying depression. One way is patient self-report, meaning the patient tells you they're depressed. Sometimes that happens. It's less. It's more rare than you would think, but occasionally they'll tell you that they are depressed. Sometimes it's staff observation of behaviors, and we're going to talk about that in a minute. Sort of some behaviors you want to look for. Occasionally it's screeners, although not enough screeners are being done. Screeners meaning the CESD or the Beck Depression Inventory, those kind of screeners that actually the patient answers questions for and will tell you whether the patient's depressed or not. And finally, behaviors. And I think for you guys, this is how you're going to know whether to do STI with a patient is just by looking at their behaviors. And for that, I really want to talk about what you see with depression and kind of looking and identifying some of the behaviors. So the way I want you guys to conceptualize depression is that depression really affects the whole brain. So let's talk about what depression looks like in terms of the emotions. What emotions would you see or what would you notice emotionally if a patient were depressed or struggling? And the emotions that you would notice are sadness, of course. And a lot of times people will think if a patient's crying, they must be depressed. And when I was a social worker, if a patient was crying, oftentimes they'd be referred to for depression, but many times they weren't. So sadness you would definitely see, but it doesn't necessarily mean they're depressed. Guilt is another one you might see with patients who are depressed. Irritability and anger, that's very common, especially in men. That tends to mask other emotions. Anxiety or kind of worry, hopelessness, helplessness, feelings of kind of worthlessness and shame are very common emotionally when patients are going through a difficult time. The other thing is, so obviously the patient emotionally will be affected, but also their cognitive abilities will be affected. So depression affects a patient's ability to think. So how that might look in clinical practice with your patients is a lot of times when patients are depressed, they'll complain of short-term memory problems, they'll complain of concentration and decisiveness. And by the way, I just want to tell you that a lot of times with older adults, they will actually look demented when in fact they're just depressed, and it's called pseudodementia. So they'll appear to be demented because they have such sort of severe short-term memory loss, but it's really just depression. So it's something you want to consider with anyone who's over 65. Executive functioning, which is paying bills and kind of going through like step-by-step process, those things are very difficult. Problem solving is very difficult when someone's depressed. Negative thoughts, and we're going to talk a lot about negative thoughts. People start thinking very negatively when they're depressed. And rumination, which is basically kind of attempting to problem solve, but kind of spinning the same thought around and around. So those are some things you might see cognitively if your patient is depressed. The other thing you'll notice is sort of their circadian rhythms are a little bit off, sort of there's some dysregulation, so their sleep might be affected, they might either sleep too much or too little, their appetite will be off, they might eat too much or too little. A lot of depressed patients have insomnia. They also have changes in their libido, usually a decrease in libido and a decrease in energy, and a feeling of just sort of general fatigue. You'll notice that. With behaviors, you're going to notice some certain behaviors. A lot of times what I found with my patients who are depressed, they basically just would want to sit around and watch TV all day. If someone watches TV all day, it doesn't mean they're depressed, but that is certainly a red flag. Also, social isolation, they're not sort of engaging, they're not talking to as many patients, maybe their hygiene's really bad, calling in sick, missing appointments. Patients, if you work with patients where they're required to sort of follow specific recommendations and they're not doing it as much, that could be a tip-off that they're going through a difficult time. So these are all things that you want to be looking for to sort of indicate that you might want to try STI with your patients, that they might be going through a difficult time.